to talk about sleep. It's a pretty broad topic, so I'm hopeful to talk about some fundamental concepts of sleep and also touch upon, at least where I am, what the major types of problems we see with sleep occur in people and a little bit of how to understand their sleep difficulties, whatever they may be. I've been an assistant professor here for a long time. I did my training here, and unless something happens, I'll probably continue to be here. So, broad overview of the topics today. I'm going to talk a little bit about why sleep is necessary, and then actually we'll talk about a little bit of the sleep disorders, and then go into some of these sleep disorders have to do with lack of sleep, and so then we're going to talk about the effects of sleep deprivation. So one of the big questions people sometimes or frequently ask is, what exactly happens during sleep? And the answer is, we're not entirely sure, but we're pretty sure it's important. Virtually every animal or insect currently known to science has some form of sleep schedule, which prompted one of the early researchers in sleep, Alan Richardson, to state that if sleep does not serve an absolutely vital function, it is the biggest mistake the evolutionary process ever made. Because as an organism, you're fairly vulnerable during sleep if you're in the environment. So the question is, why is this so common across all organisms? And the reason is, for both insects, it turns out, as well as for animals and humans, sleep is important for a few things: cognitive development, learning new things, mental health, the normal brain operation, and physical health, how the body maintains itself and its own health as well. And that becomes a problem because I'm not sure about other parts of the world, but certainly in the United States, there's a lot of adults that underestimate how much sleep they really need. They don't necessarily, because of environmental factors and other things, they don't understand the sleep requirements they should be getting. And people tend to under-recognize or underappreciate the consequences of short-term and long-term sleep deprivation. And the biggest difference between short-term sleep deprivation and long-term or chronic sleep deprivation is, you know, if you have acute sleep deprivation because you get sleepy. If you don't go to sleep for a night or two, you will be sleepy. But if you cut out an hour or two of sleep every night, you may not feel the same even if you are suffering the same side effects. And a lot of our physicians, at least in the United States, aren't necessarily that familiar with why we need sleep from a biological perspective. So if we're talking about sleep and what is it the brain does during sleep, if we look at electroencephalogram studies, we now currently categorize sleep into different stages. There's stages of sleep that occur what we call non-rapid eye movement sleep, or non-REM sleep, and rapid eye movement sleep. These have different characteristics when you are doing a sleep study and looking at a EEG, and that's how we have historically divided sleep into different stages. Whether or not artificial intelligence will change this classification remains to be seen. But the current stages of sleep, which really aren't important of themselves, I think, for this talk, but you have a range of sleep stages: N1, which is very light sleep or dozing, N2, a little bit deeper sleep, N3, or also called slow wave sleep, which is a deep sleep. There's stage 4 is no longer recognized, so we just do N1, N2, N3, and REM sleep, which is also deep sleep. And this becomes a little bit more important when we talk about how sleep changes over a lifetime. And finally, there's always the awake stage of sleep. So if you're awake, that is one that people sometimes forget, but it's a sleep stage even if you're not sleeping. The typical person will spend their 7 to 8 hours of sleep alternating through these various sleep stages. Usually they'll be awake, they doze off to sleep, that will be N1 sleep. They will then transition to N2, and then slow wave sleep. And then they will have these alternating cycles where they cycle through N1, N2, N3, and REM sleep through the night. And typically what happens is in the latter half of the night, you will spend more time in each cycle in REM sleep. And that has some implications on how we categorize abnormal sleep behaviors when people show up with unusual sleep behaviors. What time does this occur? Because if it happens in the latter half of the night, depending on the characteristics, it may be a sleep disorder that occurs in REM sleep as opposed to a sleep disorder earlier in the night that may only manifest in the lighter stages of sleep, N1 or N2. If you look at how the brain sleeps over the course of a lifespan, we know that infants and babies spend a relatively large amount of their total sleep time in the deep stages of sleep. And that's thought to be a reflection of the fact that they have a tremendous need to produce cognitive development. As you become older and leave childhood and enter adulthood, your overall sleep requirement in terms of time goes down, and you spend relatively more time in the lighter stages of sleep. One of the side effects of this that people may have noticed is as you get older, you will wake up more at night. There are a variety of reasons for that, but one of the reasons is as you are aging, you spend more time in light stages of sleep. So any particular stimulus, whether it's worry or aches or pains that have accumulated, they're more apt to wake you up compared to the deeper stages of sleep back when you were perhaps 10 years old. So we do see, and it's a normal finding, that adults will report more nocturnal awakenings at night that they can recall because they wake up easier and it's more difficult for them to fall asleep compared to children who spend more time in deep stages of sleep. How much sleep do you need? We know the average is about 8 hours, but there's a certain amount of genetic variability. Most people are going to need between 7.5 and 9 hours of sleep in every 24-hour cycle. And again, you have age can affect that amount, but the amount you need is not necessarily the same as someone else. But that hasn't stopped most of America, at least, and probably most, or at least a large number of nations where you have electrical power and cheap light sources at night, and electronic gadgets. Most people, at least in America, think they only need 6 hours of sleep, and I have to tell them that's just not true. They need more sleep than that. If you're looking at children, what are the recommendations for children's duration of sleep? This is also something that most American parents don't understand. If you're dealing with infants, they're going to spend a very large portion of the day, almost 14 hours on average, in a sleep cycle. And even up until the age of 5, with both nighttime sleep and napping during the day, the child should be spending 11 to 12, maybe 13 hours of sleep per day. I see a lot of young children in the 6 to 12 or 13 to 18 year span. And certainly my partner, Dr. Bauer, sees a lot of children who are probably getting 6 to 7 hours of sleep And that really is not recommended for anyone under the age of 18. If you're looking at milestones, educational outcomes, learning ability, children that get less than the recommended amounts of sleep tend to do worse in terms of educational attainment and mental health. One of the things that can occur or coexist with sleep, and we'll talk about this as we sort of shift from the fundamentals of sleep to some of the things you can see, some of the disorders you can see in sleep, are changes that occur in the body during sleep. And probably one of the more problematic issues is acid reflux. You actually have a fairly frequent amount of acid reflux while awake, but it's usually rapidly cleared from the esophagus because most people are awake, they're upright, so it rapidly drains out of the esophagus, and they have peristalsis that also helps clear acid secretion. So it's not usually very problematic. But we do know that if you keep acid in the esophagus, it can be a risk factor for erosive esophagitis and ensuing complications. And we also know that during sleep in anyone, acid reflux is prolonged. So anything that makes this acid reflux, which is already prolonged in sleep, worse is going to raise your risk factor for symptomatic acid reflux and complications. And we know that obstructive sleep apnea is associated also with worsened GERD, even more than normal sleep. There are a variety of factors that might play into this, but probably the most important is if you occlude the upper airway and you're generating negative intrathoracic pressure in the chest because you're attempting to expand the thorax, you're attempting to take a breath, and there's a negative pressure inside the chest, you'll probably keep or either suck acid into the esophagus or delay its clearance back to the stomach. And so really bad nocturnal acid reflux, particularly in obese people, may be a sign or a symptom of obstructive sleep apnea. And in addition to antacid therapy, obstructive sleep apnea treatment can help improve very bad nocturnal GERD if they have sleep apnea. Another common problem that we see in sleep is the inability to fall asleep, or insomnia. There are a lot of definitions for insomnia, so I'm just going to go with a general definition. Insomnia, when I think of it, is just a person that has persistent difficulty with either falling asleep for the first time or staying asleep at night. And that's if the patient has enough sleep time built into their schedule. Every now and then I'll have someone who comes and they say they're not getting enough sleep, and they have a work schedule which may only permit 5 to 6 hours of time in bed, and they're sleepy. They don't have insomnia, they just have a lifestyle that is not allowing them to sleep. Insomniacs have difficulty, even if they're in bed and have time for sleep, they have difficulty falling asleep. Why this occurs is not really clear. It's still debated. Probably the two broad categories of why this happened either are some type of learned dysregulation. You've had something happen in your life and you modified your behavior, and that behavior modification has led you to have more and more difficulty with your sleep. So it's a learned dysregulation. There's also a theory that you may have some sort of hyperarousal physiologic state, and that's why the brain can't fall asleep. And we do know that people with insomnia generally have an increased metabolic rate and cortisol release, catecholamine secretion, and various other markers that indicate that they are physiologically hypermetabolic compared to normal patients without insomnia. Part of the difficulty with examining insomnia is that it is frequently, at least in the American population, frequently comorbid with other problems. And the vast majority are going to be mental health problems. or they have insomnia because they have other medical illnesses. So if they have congestive heart failure or back pain and things, either shortness of breath or pain wakes them up at night, they can, in addition to having those stimulus, begin to expect that, and it adds to frustration and trepidation and anxiety about sleep. So a lot of these people with insomnia will have something else that will add to their insomnia. Only about 15% will be perfectly healthy and have insomnia alone. And that's also reflected in a bunch of studies. As you see the amount of insomnia report in a population go up, the number of medical problems go up. If you look at what happens physiologically, this is a study looking at metabolic rates measured by oxygen consumption. And here with the dotted line, you have normal people. So they showed up at a sleep lab and somehow convinced these people to stay in a sleep lab for 35 hours. And that every now and then they would check their oxygen consumption. And when they arrive at the sleep lab, and during the day in the sleep lab, their oxygen consumption goes up. And then when they sleep, the oxygen consumption falls. For people who have problems with insomnia, at any point during this experiment, awake or asleep, their oxygen consumption was higher, indicating a higher baseline metabolic rate. If you look at other functions of adrenal and hormone systems of the body, we also know that insomniacs, or people suffering from insomnia, will not have the normal cortisol dip at night. So during sleep, your cortisol levels generally fall, and then shortly before waking up begin to climb again. Insomniacs here, they don't have this normal dip. So there's some suggestion that this insomnia could be a learned response. You've learned, unfortunately, you've learned how not to sleep well, or your body has something physiologically going on that is keeping you from falling asleep. If you look at the brain itself, this was a study that showed that here in slide A, I don't know if it's important to know the exact regions, but you can see differences in how normal controls and people with insomnia, how their brain's activities differ. So in insomniacs, certain areas of the brain do not quiet down during sleep. And in insomniacs, even while awake, some of their brain is more active than in awake subjects. So there's some indication that regardless of whether this is a learned response or not, there are some associations with physiologic changes in both the body and in the brain. And that may be, whether that's causal, these changes cause insomnia, or insomnia results in these changes is not really clear. But it is a difficult subject to treat, and probably a talk all on its own. One of the things that you need to keep in mind if you're trying to figure out if someone has insomnia is separating it from circadian rhythm disorders. And just as an example, these are actigraphy. I don't know how familiar people are with actigraphy, but here's basically a 24-hour cycle from here to here, and the black bar is the time asleep. And most actigraphy plots will have midnight as the center point. So most people will go to bed in the evening, and they'll sleep all night, and they'll wake up in the morning, and they'll be awake until their next evening when they fall asleep. And for most people with a reproducible sleep architecture and sleep habits, this will be fairly normal. This would be a normal sleep. We do know that there is a tendency as people age to fall asleep earlier and wake up earlier. Their duration of sleep is about the same, and they're still getting most of their sleep at night, but this is what's known as an advanced circadian rhythm sleep cycle. And if you let these people go to bed early in the evening and wake up early, they'll be just fine. It's usually their families don't want them to go to bed early, and they have nothing to do early in the morning. So it's just their sleep is off compared to their environmental rhythm. Teenagers, at least in America, will do the opposite. They will usually like to stay up late and they will sleep in, particularly on the weekends when they don't have school. And though this would be a delayed sleep phase. Usually they'll be very sleepy because they have to get up for school. Again, if they didn't have to go to school and they could sleep all day, they would not be sleepy. They would be just fine. But this is a delayed sleep phase. There are a few others. Free running sleep can be seen in people who have blindness and they don't have something to entrain their circadian rhythm. And they'll be getting a roughly normal period of sleep, but they're just not cued into their environment. So most people's circadian rhythm of when you're awake and when you're asleep is slightly longer than 24 hours. So you'll usually see this form of sleep on their actigraphies. People with insomnia or irregular or fragmented sleep, which I see a lot of at the VA, they'll nap or fall asleep at any particular time. It's very difficult to get these people to go to bed at night because they're sleeping so much during the day, they won't fall asleep at night. So sometimes you have to separate insomnia, I can't fall asleep, from a circadian rhythm disorder. You know, I'm sleeping so much during the day, I just don't have very much sleep drive left at night. So just something to keep in mind. What I usually recommend for most of the rotating residents is just to get a really quick sleep history to try to separate these elements from one another. So how long has it been going on? Usually insomnia is something that's chronic. Everyone has insomnia. If you have a test in 2 days, a lot of people will have short-term insomnia, and that's usually self-limiting. But if you're looking at chronic insomnia, this usually has been going on for years. And what's the biggest issue that they're having? Is it falling asleep or is it staying asleep? And then I'll usually ask a bunch of details about how they go about their day. What time do they wake up? Do they take any naps? Are they scheduled naps? Are they intentional naps? Do they doze off unintentionally? How long are the naps? What time do they head to bed? And how long does it really take them to fall asleep? And how many times do they wake up at night? Once you have, and some of these people will not know. So if you don't know what time you normally go to sleep or normally wake up, you probably have a schedule like this. Because most people will have an idea of when they can go to bed. So it's an idea, it gives you some opportunity to explore how cognizant the patient is or how aware of the patient is of how their sleep habits may be affecting their sleep. And then you also want to check and make sure their weekend schedule or when they're not working or where they're not going to school, if that's substantially different, because that's where these delayed sleep phase people will have their problems. They'll say, I'm so sleepy, I can't fall asleep at night. And they'll make up for their lack of sleep on the weekend when they don't have work and they don't have school. And usually you have to convince these people to change their schedule to move their sleep times up so they can get their entire 7 to 8 hours of sleep they need at night in an appropriate time. We recommend that all adults, in addition to children, have their own bedtime routine, a bedtime ritual. So you want to avoid an irregular sleep schedule if you can. You want to, if you can, avoid daytime napping because it will dissipate your sleep drive, which we'll talk about in a moment. And if you're having problems with insomnia, we recommend avoiding caffeine or alcohol at any time, really. But caffeine afternoon or evening is really something that should be avoided. What you also should be avoiding is if doing any physical exercises or a lot of mentally stimulating activity, either right before bed or in bed. Going to bed and then worrying about various matters while you're trying to fall asleep is a terrible way to fall asleep. So sometimes we'll tell these people to go find some other spot, like at a desk, and set aside like 20 or 30 minutes to worry at that location outside the bedroom, write down their worries. When they go to bed, they shouldn't be thinking about that. If they think of something that worries them, they can get up, they can go write it on a journal, and they can worry about it tomorrow. But we want to try to eliminate this worrying in bed. Watching TV, reading books, anything that's keeping you awake in bed, we want to avoid. We want to train people that once they get into bed, It's part of their bedtime ritual. They either go to sleep or they have sex. Those are the two activities we want the bed to be associated with. Anything else, reading, watching TV, could be done somewhere else. So that's a lot about the behavioral aspects that we see in sleep. There are also some sleep disorders, the most common of which are probably going to be either obstructive sleep apnea or central sleep apnea. Obstructive sleep apnea is an inability to breathe or ventilate because of an upper airway closure, whereas central sleep apnea is going to be a temporary cessation of ventilatory drive. The brain doesn't want to take a breath. And they have different causes, but they're both related to something called loop gain, which I'm not going to talk about here. But probably the most common things in obstructive sleep apnea is knowing the difference between an apnea, which is described here. So you have two breathing sensors. You have a little sensor measuring changes in pressure, usually on the nose, and you have a sensor that's registering temperature change, usually placed over the mouth, and that's your airflow measurement. And you'll usually be wearing a belt across the chest and the abdomen to measure movement. And you'll have a pulse oximeter. So here you have someone who continues to take breaths, but you don't register any pressure or temperature changes. So this would be indicative of an obstructive apnea. The airway has closed off and you're really not moving very much air at all. It doesn't always have to be near complete occlusion. You can have the same things where you still have continued respiratory effort and you have a reduction but not complete elimination of airflow, and that's usually a hypopnea. We only recognize these as hypopneas if there is a consequence, and we define that as a fall in oxygen. So if you take a series of smaller than normal breaths, but your oxygen level stays fine, then it doesn't count. But if you take a series of small breaths and your oxygen level falls by 3 or 4%, so from 95 to 91% or 93% to 87%, we would call that an obstructive hypopnea that's interfering with your breathing. And finally, just to separate these two from central apnea will have the same types of changes in airflow. There won't be any airflow, but it's not because the airway is blocked. It's because your brain has stopped breathing for whatever reason. And so you don't see any respiratory movement. And of course, if there's no muscle movement, you will not be moving air. So this would be a central sleep apnea where you have an absence of movement of the chest, and that's reflective of an absent ventilatory drive by the brain. And so those are the big things that we look at in the sleep lab when looking at obstructive sleep apnea. And there are a bunch of things that can play into obstructive sleep apnea. Probably the top three in the American population are going to be a male gender is a risk factor, increasing body weight, and increasing age. And there are a variety of studies looking at the prevalence of sleep disordered breathing. And as you grow older, you generally have more and more rate of sleep apnea. And that's everyone sees as you age, everyone gets wrinkles, unfortunately. Your skin becomes a little bit more lax. And the connective tissues holding your airway open between the trachea and the posterior oropharynx is all smooth muscle and tissue. And as those become more lax with age, you have a higher degree of airway collapse. You can also see a difference in terms of sleep disordered breathing between various ethnic groups, Caucasian, African American. This in America is a hotly contested subject. It's not quite clear why this is. Some of it may be related to genetics and how your brain maintains upper airway tone. Maybe some of it's related to differences in craniofacial bone structure. It's not quite clear why these differences exist. Earlier, I said that the male gender is a risk factor for sleep apnea. Females are usually very good at not having sleep apnea, at least until menopause. Postmenopausal women will generally begin to have sleep apnea at the same rates of men in the same age group. But until then, it's actually pretty rare to see females with obstructive sleep apnea. Why the airway collapses? There are a bunch of different methods, but probably the leading cause is going to be age and obesity. So if you have someone who has more adipose tissue, you have higher rates of weight pushing and in on the throat and collapsing it. And you also have a bigger tongue because you have more adipose tissue in the tongue. And that will narrow the posterior oropharynx, which is where sleep apnea occurs. In contrast, people with a lean or lower BMI, they'll have less adipose tissue in the tongue. The posterior oropharynx will have a little bit more openness, and there won't be so much pressure on these structures to collapse. And you can see that on CT scans in these sagittal cuts as well as these cross-sectional cuts here. More adipose tissue generally results in a narrower airway opening. How we treat sleep apnea is a hotly contested topic. There's a lot of studies that retrospectively have shown differences in outcome, but when we do randomized controlled trials, it's been very difficult to show improvements in health. And so there's this idea that not all sleep apnea is equal. So there could be sleep apnea that have different phenotypes. And so you could have sleep apnea that's causing disturbed sleep, maybe waking you up at night, an insomnia type of obstructive sleep apnea. You could have sleep apnea and have no symptoms. You don't feel sleepy. You're not waking up. You may not be bothered by your sleep apnea. And you may have sleep apnea that may not wake you up at night, but nonetheless keeps you sleepy or is associated with sleepiness during the day. And of all these different phenotypes, it appears that sleepiness, the excessively sleepy people, tend to have a different survival probability. So maybe it's not just how many events you're having each night, it's how are those events affecting you in terms of your sleepiness. But so far, this type of scoring system is just more of an area of research than current practice right now. Now, how do we treat sleep apnea? We treat it with, generally speaking, CPAP therapy. There's a couple of ways that CPAP therapy, which stands for continuous positive airway pressure, there's a couple different mechanisms by it that makes it work. One is you produce a positive pressure to keep the walls of the airway apart, so you prevent closure just by splinting the airway open with this air pressure. That's been the historical teaching. But there's also a concept of tracheal tugging. We know that people on CPAP, if you have super atmospheric pressure applied to the airway, you'll have more air in your lungs, and that will at any particular volume. And having more air in your lungs moves the heart and the mediastinum down, and that will tug on your trachea and cause your trachea to become more taut or tighter, or it's going to be stretched. And if you think of any collapsible tube, if you stretch it out, it is more difficult to collapse. So these are the two mechanisms by which CPAP probably helps. There's actually a very interesting experiment using an iron lung where they made sure that the iron lung ventilator did not, I don't know if anyone's seen the pictures of the iron lung, but they made sure the contraption did not push on their neck. And just by changing the atmospheric pressure around the chest, you can move the mediastinum up and you can induce sleep apnea just because of the floppiness you can induce in the trachea and the posterior oropharynx. There's a bunch of mathematical models that can also describe why this airway closes. There's a whole lecture on that, so I don't have time to go into it. But basically, if you are moving air through a tube and you have varying pressure levels from the beginning of the tube to the end of the tube, and you have a varied pressure around it, you can induce collapsible states in that tube. And that's how obstructive sleep apnea is thought to work as well. Why do we care about sleep apnea and why do we care about treating this? Most of these are going to be from retrospective studies where we see people that had severe sleep apnea had a lower survival rate. And if you had severe sleep apnea, where you had more than 20 apneic events per hour of sleep, if you put those people on CPAP versus people who didn't want to do CPAP, there was a survival advantage. So these are retrospective studies. We're not sure, and as a result, we're not sure if CPAP was the reason this mortality difference exists, but that's what is the impetus behind a lot of the treatment for severe sleep apnea, is this mortality trend that's historically been observed. So those are some of the common problems of sleep. We're going to go talk a little bit about how does the brain control sleep, because it's going to be important for the next topic, hypersomnia. So we know, at least in the environment, if you're an animal in a forest or on a plane, staying awake could be very important for survival. As a consequence, the brain has a number of mechanisms to wake you up and to keep you awake. There's a lot of neurological centers that accomplish this using a variety of neurotransmitters. There's also things that not only wake you up, but things that make you fall asleep. So sleepiness and sleep-related behaviors like yawning, diminished alertness, eye rubbing, all of these sleepiness behaviors will be diminished if you're in a state of high motivation. So if there's something in the environment that's causing you stress, if there's a lion or something that's chasing you, even if you're sleepy, you will stay awake. Just because you're put into an environment of low motivation or low stimulus doesn't make people sleepy. So my favorite thing to tell all the residents is, if you eat a large meal or you're in a warm room or you're having to attend a boring lecture, you shouldn't fall asleep unless you're sleepy. If you're getting enough sleep, if you're in a boring lecture, you'll just be bored, but you're not going to fall asleep. So you can usually tell at noon conferences who has not been getting enough sleep, because they will fall asleep. If you have severe enough sleep deprivation, you can have microsleeps where you will fall asleep unintentionally while awake, even for a few seconds. And this is probably related to how traffic accidents can happen. There's no known biological marker that we can utilize to look at how sleepy is someone. We just have to rely on what they tell us. But we have some models about how behaviorally the brain governs sleep and wake. And so there's this concept called a sleep drive, or process S, that regulates sleepiness. And there's a process called the wake drive, or process C, for circadian alerting signal. And these are both cyclical in nature. We do know that adenosine accumulates in the brain while awake and is cleared during sleep. It's thought to be related to sleepiness. Caffeine is an adenosine blocker, which makes sense and why this may help with alertness in coffee and other soft drinks. But these two processes, process S and process C, are the models we use to explain sleep behavior. And if you look at the various alertness or stimulation from circadian centers in the brain, you will see that beginning around 8 o'clock or 9 o'clock, you will start to see an increasing amount of alerting signal from the circadian signal system, and it will go up and up and up during the day. At some point, your circadian clock will begin to deactivate itself and the circadian alerting signal falls. And this will then repeat the next day. And this is a cyclical activity level maintained by the brain. Your sleep drive tends to accumulate during wakefulness. So the adenosine accumulation or sleep drive will accumulate during the day. At some point, your sleep drive will overcome your circadian alerting signal. That's when you fall asleep. And while asleep, your sleep drive is dissipated. It's sometimes useful to explain this model to people who sleep during the day, because you can say, well, if you slept here and your sleep drive goes down, you can't fall asleep at night because you have such a reduced sleep drive. Remember that when you fall asleep, it's not because your circadian alerting signal is turned off, it's because your sleep drive has overcome or is greater in magnitude than your circadian alerting signal. So people napping during the day tend to have more problems with insomnia at night because their sleep drive is not in a state to change their behavior from wake to sleep. So I hope that made sense. There's a bunch of different areas in the brain that are involved in this. In terms of narcolepsy, which we're going to talk about next, these are probably the important parts. There's these orexin neurons that go to various areas, mostly in the midbrain, and send projections everywhere that control arousal and alertness. And narcolepsy, which is a type of hypersomnia that we see on occasion, is due, or not, type 1 narcolepsy is due to a loss of these orexin neurons. So if you have a loss of orexin neurons, and these orexin neurons are involved in maintaining wakefulness by stimulating these various centers and keeping the brain awake, this is one of the reasons narcoleptic patients have difficulty maintaining awake states. They can wake up just fine because there are different centers of the brain that control waking up, but maintaining wakefulness is difficult for narcolepsy. One of the things you can see with narcolepsy, in addition to sleepiness during the day, is cataplexy. So cataplexy is a either partial or full loss of muscle tone, generally in response to emotion. They don't pass out, they don't lose consciousness, they just have a loss of muscle tone. And this is thought to be one of the mechanisms related, or one of the malfunctioning mechanisms in the brain. Normally during sleep, the midbrain will induce a paralytic state, or will induce paralysis, so that when you're dreaming, you're not acting out your dreams. Because if you're asleep, you can injure yourself if you're acting out your dreams. If you have a damaged orexin system, you may have this system inadvertently activate during the day in response to an emotion. How this affects a narcoleptic depends on the patient. Some people will just have weakness in the jaw, so they will avoid funny situations or jokes because it makes them slur their speech, or they have to sit down because they have leg weakness. There was one patient I have that will have full body cataplexy, and was at a sports game in the stadium, and some ref made a bad call, and someone in the stands yelled at the guy, said, "Can you believe that call?" And it was so startling, he had a cataplexy attack and just collapsed in the stands, which he thought was pretty embarrassing. So narcolepsy is one of the diseases that seems to arise in terms of hypersomnia, or states of excess sleepiness. And we're excluding, in this case, the most common, which is probably people not getting enough sleep. But there are other things, such as narcolepsy, that can cause sleepiness during the day, even if you have adequate sleep opportunity and you're getting adequate sleep. So narcolepsy is the prototype because it involves a lot of the neuronal systems involved in how the brain regulates sleep and wake. There are a bunch of other things that can cause a central hypersomnia. We tend to think of narcolepsy as a disease by itself, but there are a variety of neurological diseases that can result in narcolepsy. A lot of the dementias, Lewy body dementia, multisystem atrophy, any degeneration of neuronal structures in the brain can affect the neuronal structures in charge of keeping your sleep and wake states organized. Narcolepsy seems to be associated with these, but they don't always have a dementia state. But it is a pretty disabling disorder, but it is pretty rare. Narcolepsy, as I mentioned before, will cause sleepiness and cataplexy. Other behaviors you can see in narcolepsy are hallucinations as you fall asleep. You will misperceive things that aren't there, and you'll have sleep paralysis, where people will wake up, but their midbrain has not gotten rid of the paralytic state, and so they can't move. Most people will have an episode or two of sleep paralysis at least once in their lifetime, where they wake up and they're not able to move for a minute or two until their midbrain reestablishes control where the cortex can move the body. But for narcoleptics, it's more common. So I mentioned earlier that hypersomnia, we try to exclude insufficient sleep, not getting enough sleep, but it is a problem. And if you look at trends over time, you see that at least in this American survey, there's been a decrease in the amount of sleep people think that they need to get over time. And it's really, while this doesn't show a very big change, this may be just 30 minutes over these 20 years. If you compare sleep now compared to the 1960s, we're probably getting on average 2 hours of sleep less per night. So it is a problem. Anytime I have a patient with hypersomnia, the very first thing that you want to make sure of is, are they actually getting enough sleep, in my opinion. This is also important because there are a variety of studies that look at sleep duration and mortality. And this is one such study. Most people need 7 to 8 hours of sleep. The relative risk of death, at least cardiovascular death, tends to go up as you get less sleep per night. There are some people who can normally get 6 hours of sleep at night and be just fine, but not most people. If you're seeing someone who's, for whatever reason, getting 4 to 5 hours of sleep at night, they have an increased risk of cardiovascular death. Whether that's the lack of sleep or maybe they have insomnia and a physiologic hyperarousal state, it's unclear. You also see a U-shaped curve or an increase in mortality if you sleep longer. That's currently thought to be because of comorbid medical conditions. If you have medical issues, you may be getting more sleep, and so maybe this is an association. It's unclear if this is an association or a causal relationship where getting short sleep can increase your risk of death. In addition to duration, the regularity of which you sleep may also be a risk factor. Oh, I don't know how I did that. This was a study looking at how people sleep. Do you sleep about the same time each night? Do you have a little bit of variance? Or are you one of those people that has a great deal of fragmentation in sleep? These people that have very fragmented sleep have an increased risk of death. So we try to emphasize healthy sleep because duration and regularity seem to be associated with improved survival, even if we don't fully understand the causes. But we do know that sleep deprivation has a variety of consequences. If you are sleep deprived, we know that there are hormonal changes in sleep. With the lack of sleep, ghrelin increases. Ghrelin is a hunger stimulus. Leptin decreases. Leptin is a satiety or appetite suppressant hormone. And so you'll have ghrelin increase, leptin decrease when you're sleep deprived. And as a result, hunger and appetite increases in these studies. We know that people who are sleep deprived tend to have higher rates of insulin resistance. So they may be not only eating more, but they may have more insulin resistance, making diabetes not only more likely, particularly in people who are already obese and have sleep apnea, but also more difficult to control. And we know that if you look at people who are sleeping less, they tend to have higher rates of obesity. And it's thought to be maybe this is related to influences on those ghrelin and leptin levels as a result of their short sleep. If they have a higher chronic appetite, maybe that is why you see increasing obesity with short sleep times. We also know from series experiments that sleep or a lack of sleep is associated with increased pain. This seems to be mostly the perception of pain. Doesn't necessarily make sleep deprivation doesn't make something more painful, but it makes the brain's response to a negative stimulus like pain greater. And so these people who were in this study, if they experimentally controlled how much sleep they got, and they had their finger in a little device that produced an unpleasant sensation, the sleep-deprived people had to withdraw their finger earlier than people who were not sleep-deprived. Experimentally, does this mean anything? We're not sure, but it could also explain if you have people with chronic aches and pains, chronic arthritis, short sleep may make those chronic aches and pains harder to deal with. And finally, we also know that sleep or lack of sleep can affect your mental performance. There's a variety of studies. I've just selected a couple from the medical literature. It looks like tasks requiring attention are more vulnerable to sleep deprivation than executive functioning. So executive functioning would be complex planning, sequencing, understanding a situation, planning how you're going to fix the situation. Those are somewhat diminished, but attention is certainly diminished in sleep deprivation. And if you're dealing with a stressful situation, the combination of lack of attention and impaired executive skills may be a problem in the healthcare setting. So being able to regulate your mood in a high stress environment, enabling good communications can be difficult. As I mentioned before, acute sleep deprivation, generally people notice because they're very, very sleepy. But chronic sleep deprivation, an hour or two of loss a night, generally does not result in sleepiness, even if it does result in impaired performance on testing. I have one study, and this was an anesthesia study looking at residents either coming in on a normal day or coming in post-call to a simulation center, and they gave them a couple of scenarios to see how they handled this. They wanted them to set the anesthesia machine room up and the equipment up, and then they did an intubation on a test mannequin, and then they gave them a couple of crisis scenarios for crisis for anyone, but also probably crisis for anesthesia. So intubation of the esophagus instead of the trachea, followed by anaphylactic shock, and anesthesia-related bronchospasm, followed by ventricular tachycardia. So things that are going to stress both your attention ability and your ability to plan how to deal with the situation. And their conclusions were that the post-call residents, to no one's surprise, the post-call residents or sleep-deprived trainees were less likely to handle these situations in a satisfactory fashion. So if you had an anaphylactic shock and esophageal intubation, anesthetic drugs were less likely to be appropriately stopped. 75% in the control group, in the rested group, only 38% in the sleep-deprived group. Administration of inappropriate anesthetic drugs at that time were more likely to never be stopped, about half of the sleep-deprived group versus only about 20%. So sleep deprivation is not going to necessarily make you forget how to intubate, but it may impair your ability to deal with simultaneous crises where you have to pay attention to a number of different things. And that's generally how sleep deprivation sneaks up on you. In addition, there was a much higher rate of wrong dose of administration medications, epinephrine, and far more people gave antibiotic that the patient was allergic to compared to those who were rested. So these are sleep deprivation will affect you not head on, but it will affect you when you're not looking, when you have difficulty paying attention. Hypotension was, hypotension was noticed only in 8% of the sleep-deprived states, But about 40% of the rested states notice the hypotension during these crisis scenarios with this particular scenario. So it's just a difficulty in terms of processing information. There are a bunch of other stuff in terms of chronic sleep deprivation, but I didn't think that we had time. I'm hopeful that we've had a little bit of overview about why sleep is important, what it's useful for, some of the consequences of lack of sleep, and the variety of sleep disorders that, and certainly not a full list, but a variety of the sleep disorders that we see in our clinic. And hopefully that made sense. And if anyone has any questions, I'm happy to answer them.
Thank you, Dr. Cross. And, будь ласка, задавайте свої питання, хто має питання. We have in chat a question from Olha. What sleep characteristics are typical for patient on mechanical ventilation, and how should this be addressed in clinical practice?
So I wasn't able to hear the first part. So what was some question about ventilation?
What sleep characteristics are typical for patient on mechanical ventilation? I know means maybe what kind of disturbances could be with sleep in patient on artificial ventilation or supportive ventilation. Yes, and what kind of strategies must be done?
So I'm not sure of the answer. I would give two. So there are certain changes that we would expect to see when patients are asleep. Typically in the ICU, we don't make any changes on the ventilation on our ventilators awake or asleep. But we do know that there are changes in ventilation. Generally speaking, in people who are not mechanically ventilated, when you fall asleep, you have a loss of muscle tone. So your functional residual capacity, the air in your lungs falls. Your tidal volume falls as well. And so you'll have a rise in carbon dioxide. Typically, the body will make up for this by breathing faster. So it has faster, shallower breaths, but you still usually see a slight increase in carbon dioxide. The brain has different responses to hypoxia and hypercapnia in sleep, but we don't tend to worry about that in mechanically ventilated patients in the ICU. In some of our patients with amyotrophic lateral sclerosis who are on home ventilators through either a tracheostomy or through a face mask, generally we try to adjust it's usually a pressure control type of ventilation, and we try to adjust their ventilator to achieve a rapid shallow index. Everyone familiar with rapid shallow index? So we try to adjust their ventilator so that the estimated tidal volume and respiratory rate is kept within a certain ratio. And ideally, if you have a pulse oximeter or the ability to monitor carbon dioxide, that's also useful. But we want to achieve usually a tidal volume of, if you put breaths per minute divided by tidal volume in liters. So let's say 10 breaths a minute divided by 1 liter tidal volume, the rapid shallow index would be 10. We try to keep the rapid shallow breathing index less than 60. That's what I do. So if you have a tidal volume of 500 or so on a sleeping ALS patient that's using a mechanical ventilator at home, and their rates are less than 20, usually you'll get a rapid shallow index that seems to be favorable. If you have someone who has mechanical weakness and needs a ventilator at home and they're breathing increasingly fast, it usually means you're not getting them enough volume at night. I don't know if that answered the question.
Thank you. I hope it's understandable for us. And please, Izo, you think your question.
Yes, thank you. Good day, Dr. Cross. My name is Issa. I'm a medical student. So in the lecture, you mentioned that high energy activities like reading and using a gadget and stuff while in bed is discouraged. For for me, when I read in bed, I tend to be more sleepy and then fall asleep in a short space of time. So I was trying to figure out how does that really work because I noticed I would never want to read in bed because I'm just end up falling asleep much sooner than I anticipated.
So some people will, I have several patients who will watch TV or listen to music. For people who are struggling, and if you're not having any problems with insomnia, then I don't really care. It's people who have insomnia and have difficulty falling asleep. We want to minimize any neuronal stimulation. So reading in bed, watching TV in bed, even listening to music or the radio in bed, if you hear sounds, your brain will attempt to decipher language. So that's going to engage neurons. So people who are struggling with falling asleep, one, I want to try to quiet down as many neurons as I can. And two, a lot of them have maladaptive beliefs. So I want to, if they expect that it takes them 3 hours of reading to fall asleep in bed, then they will make that come true. So you want to try to extinguish that behavior. But for people who don't have problems falling asleep, it's just a recommendation, not terribly strong recommendation.
Thank you, Doc.
And next question from Natalia, please.
Thank you very much, Dr. Cross, for your speech. And I have one question. You said about the connection between pain syndrome and bad sleeping. What about your data, maybe, of your investigation? Do you have some connection between bad sleeping and disorders of immune system, included autoimmune diseases start?
In terms of autoimmune disease, I can't recall any studies offhand. In terms of the immune system, there are studies that suggest that, there are studies that have been done comparing vaccination effectiveness in people who get a vaccination when they're sleep deprived versus vaccinations when you're not sleep deprived. And people, I think at their initial follow-up at around 4 weeks, had less antibody titers in response to vaccinations when they were sleep deprived. Subsequent studies seem to suggest that at 6 to 8 months that difference disappears. I can't remember if those sleep deprived antibody titers went up or the rested patients' titers went down, but there is at least an acute impairment of the immune system. And there are other studies looking at rhinovirus, weakened rhinovirus administration in the nose of sleep deprived versus rested subjects, and more sleep deprived patients acquired symptoms from that. So there's some transient effects with acute sleep deprivation on the immune system, but I'm not sure about autoimmune disease.
Thank you very much. Thank you.
Thank you, then, Dr. Cross. And we have next question in our chat. What are your recommendations for the most comfortable sleep? What is your attitude toward breathing techniques?
So for breathing techniques, I don't know that I have any. Most people will have a preferred position for sleep, either that's what the behavior they've learned to fall asleep in, or they have something that prevents them from falling asleep in a different position, shoulder pain, hip pain. So generally speaking, if we're looking at just falling asleep, whatever is most comfortable. In people who have sleep apnea, and there are variants of sleep apnea that are worse if you're sleeping on your back. And if that's an issue, and people don't want to use a CPAP machine, and I have a sleep study showing that if they sleep on their side, their sleep apnea mostly goes away, then I will usually recommend sleeping on their side. and there are devices that can help with sleeping on your side. The cheapest one is getting a t-shirt with a pocket, putting a little tennis ball in there, sewing it in there, put it on backwards, and then you have a lump on your back, so you will train yourself to sleep on your side.
Thank you, Dr. Cross. Thank you for your interesting lecture. Yes, and we have bright discussion. It's so important topic for everyone, I think. Yes, so it was very helpful, and we already have, I hope, new knowledge, because the topic of this about the sleep, it's not so popular, yes, in our education and so on. So it's very unusual information, for most common for us. So thank you.
All right, well, thank you very much.
Thank you very much. Bye-bye. See you next lecture.
До побачення усім.